So my name is Mohamed. I'm based at UBC in Vancouver, but this research was done in Somalia. And I was supposed to be here with my colleague, who's a PhD student and also working at the Somali National University, but unfortunately he couldn't be here, so I stepped in to do this. This is a project that was at the height of COVID, so we did it by the fly. COVID, it was around October, November, December in 2020. And at that time also there was severe drought in Somalia and also the ongoing conflict. So it was quite a challenging time. It's a small project, so we had a few participants in this training. But nevertheless, it kind of opened up a lot of understanding of what was going on in the country and gave us the motivation to go on. So I'll give a bit about the background, methodology, results, conclusion, and also talk about what next. Can you hear me well? Yes. So in terms of the Somali context and also in areas of conflict, the studies have shown that conflict-affected populations suffer from high rates of mental illness, including anxiety, depression, PTSD, and substance use. In the Somali context, both the same? Okay. So in the Somali context, it's actually seen as one of the areas that have had protracted conflict for over 30 years. And in some studies mention that 1 in 3 in the country suffer from one form of mental health condition. So that's pretty high and alarming. The other aspect is the severe shortage of mental health services in terms of healthcare facilities, in terms of human resource for mental health as well. Some of the studies show that probably about 3 psychiatrists at one point in a country of about 18 million, so really limited. And that's kind of what led us to look at this study. So it was based on a trainer for trainee using MHGAP, the Mental Health Gap Action Program. The study was done. The project itself was funded through WHO and the Ministry of Health, Somalia, and also the Somali National University. So we decided, okay, let's look at what's available in terms of the human resource and what is the knowledge capacity for this group of selected health professionals that were drawn from 5 regions of the country. So we look at we assess the baseline and also post-training knowledge of MHGAP, priority conditions among healthcare workers. We also looked at the effectiveness of the training in terms of communication skills, in working with individuals who are dealing with mental health issues, and also did a follow-up interview after 5 months with only 4 participants looking at their post-training attitudes toward the MHGAP conditions. So overall, we had 24 participants, and we did pre and post test with follow-up qualitative interviews with only 4. At the beginning of the training, on the 0 day of that, we did a pre-test. So the pre and post were the same questions, about 16. And we looked at what the scores were at the beginning, then did the training for 8 days. And participants were drawn from 5 regions, specifically from South Central Somalia. So what was not included was the northern part, so that's Puntland and Somaliland, but the rest were included, and we got a mix of healthcare workers, doctors, nurses, social workers, public health, as well as midwives. The training was for 8 days, conducted in December 2020, focusing on priority MHGAP conditions. Then At 5 months, we did a follow-up interview with 4 participants. So pre and post test, 16 multiple questions based on the knowledge, which is available on the MHGAP manual. Then interviews with 4 quantitative data. We looked at the test scores analyzed using mean score, and qualitative data analyzed thematically, looking at confidence, communication, and the impact of the cascade training. So in terms of the priority conditions, we decided to contextualize in the Somali context. So we talk about, I believe, 7, the ones that are shown here, plus for children and adolescents included, and also communication skills as part of the modules. We also focused on human rights aspects, considering that for individuals who live with serious mental health, they go through significant human rights issues in terms of physically chaining them or locking up in standalone psychiatric hospitals using physical restraints as well. So we also focused on the human rights aspect. So looking at the background of the folks who were part of this study, we had about 24. And one of the things that we realized is that we had more male than female, even for the nurses, which kind of speak to the impact of the conflict that's going on around there, and who is privileged to go to school and become a healthcare worker. The other thing that was really interesting was for the doctors, nurses, midwives, and social workers as well, is whether we asked them whether they had any training in mental health at the university or college level as part of their pre-service curriculum. And 37% say they did not have any mental health training in terms of theory, which was quite alarming to us, knowing that that is a basic training that everybody goes through. But the other thing that we also found out was that about 60% did not have any clinical or practicum in a mental health facility when it comes to mental health as well. And that kind of gave us an idea of how can we address the gaps in terms of training and capacity going forward, considering that there was no a systematic kind of curriculum across the board for the universities in terms of medicine or nursing and so forth. And in some universities, they actually even didn't have any mental health curriculum at the pre-service level. So that kind of gave us ideas where to go next. And I will talk about that at the end in terms of what's next. So for pre and post, so we took the average here. At the pre-level, we had the highest was about 13. But after the test we did, after the training of 8 days, we see a remarkable improvement where the average was about 15 out of 16 on the same test score. So we saw quite a big improvement in that regard. So for the qualitative interview, we looked at there are a number of thematic areas that came about: interprofessional. Sorry, that's the one I was talking about. I guess I'm not coordinating well with that. So the pre-test, the average was about 11, and the post-test, as you can see, is 15. So remarkable improvement in terms of the knowledge base for MHGAP. Qualitative findings, thematically, we came to understand there was, after the training and also for these TOTs to go back to their regions and actually further train about 120 healthcare workers. There was, feeling of increased personal and professional growth, considering that the basic training in mental health was very much limited. We also found out there was health system strengthening, and also areas of constraint in terms of the health system. In terms of professional and personal growth, one thing was that there was an uptake in terms of integration of mental health services, so participants incorporated mental health assessments into primary care services. So whether they were at the general hospital or a community health center or they were doing outreach, they started doing assessment and, addressing mental health issues at their place of work. Improved access to services, mental health assessments became routine, reducing the need for patients to visit specialized care, which again were not that much available. They were far in between, so they were able to provide these services at their local level. The other thing was that for some of these healthcare workers, they had their own private clinics or private facilities, and they were really encouraged to provide mental health services as part of their private clinic business as well. So going outside the public health system all the way to the private as well. In terms of health system training, after the TOT training we did in Mogadishu, there was cascade training. In these 5 regions, we had about 120 more healthcare workers that were trained. In that sense, kind of increasing the capacity of health workers at the frontline level. Advocacy became also another issue for this group of over 100 healthcare workers trained now in mental health. They went to the ground, say that we need to do more in terms of addressing mental health, given that the country is going through challenges due to conflict and the climate crisis that is going on. And the other thing is that there were designated 10 community health centers after this training, and all of them adopted integrated healthcare services where mental health became part of the services they were providing. And the other thing is that the establishment of private mental health clinics across in this region to also support for those who can afford to go to private facilities. The study also realized that there were obviously restraints, considering this is a country that has gone through a lot of challenges. But one of the key issues they talked about was even for serious mental health conditions like psychosis and bipolar and so forth, and even epilepsy, in terms of neurological conditions, there were literally inadequate supply of medication. So there was not much they could do for people who really need treatment or pharmacological interventions. There was really limited supply of the same. The other thing that was again expected because of the lack of stronger central government and also regulation and authorities that address that, there is a availability of counterfeit medications that further complicate the issues. So a lot of healthcare workers mentioned that they actually don't know which medication is real and which is not, so which is quite also a very big challenge in that regard. However, there are also opportunities for system strengthening that came about. One of them is increased awareness due to the training and also the talk about mental health at the primary health level and also outreach, and that there was more push to train volunteers and community health workers in order to raise awareness and also to provide basic assessment at the community level. So in conclusion, out of this small study, we realized that there was positive outcome in terms of capacity building. We saw that there is need to address these health system limitations around medications and also lack of integrated healthcare services as well, and also the need for scaling up evidence-based interventions using modules like the MHGAP. Given this was a small scale in terms of the study we did, but also we did a systematic review of the literature. We did situational analysis as well. Sure about. Yeah, we did a situational analysis, and that kind of helped us to build up evidence in terms of really looking at what else can be done. So based on our small study, we decided the most important thing for us to do at the university level was to train more healthcare workers and also to address the gaps at the curriculum level, both for School of Nursing and also medicine. And with that, we were able to get some funding for the next few years to do both. So from January next year, we'll be training about 450 healthcare workers across the country on MHGAP, and also we are partnering with some of the universities in the country. Somali National University, which is the public national university, and a few others will also be part of this in terms of developing a curriculum based on the WHO pre-service curriculum that was just developed. It's not still conclusive, but there's also opportunities that we are, Africa CDC and EMPRO will be providing leadership training for some of the mental health focal points across the country, so that we have at least folks who will be having that training to undertake and be part of this project as well. So, lastly, I'll just say that this was all possible because of funding from UN Peacebuilding Fund, CIHR, and Health Research BC in Canada. Thank you. That's the end.